Are you recording them? So are we able then to, are you able to watch over them at a different time afterwards then? How does that work?
Absolutely.
Okay,
yeah.
that's amazing.
It takes a bit of time. It usually takes 2 or 3 days. It comes from here to Zoom, and we upload it onto our blog page.
Okay.
So if you're on our website, a bar across the top, look on the blog, and it will be there, and it will be with Kelly's amazing. She's going to stick with me for the next 2 or 3 weeks, and we're going to sort of follow this up. If it feels right and it works well, then we do a series of 3 or 4 treatments on her shoulder, and link that together, and just see, you know, I don't know. We'll just make this up. I don't know. We'll just make this up as we go along and see how it rolls. Well, let's you're up for some fun then, Rebecca. So as I'm going to do my promotion of my material that I'm using, I rather like this stuff, and I'm using it more. My pot's getting empty, Mark. See, look, it's getting empty. I found this on. Can I say Amazon? Can I talk about Amazon? Is that all right to talk about Amazon? Anyway, I found this stuff. Let me put that in the camera. There you go. So it's shea butter and coconut butter, and it smells like peanut butter, and I love it. And I highly recommend it. And this pot of 500 grams, I don't know, I should get a promotion for this. This pot of 500 grams cost me 10 quid, which I thought was a really good price. Anyway, there you go. That's the end of my pitch. Right, so those of you who did not read the mailing or picked it up or whatever, Kelly's a swimmer. She's teaches swimming as well. She's doing her level 3 sports massage course with us, and we had a conversation earlier in the week, and I bribed her into coming because she's a superstar. So, okay, so what we've got is pain in the left shoulder. Where are we gonna? Let's have a look. You're gonna come walk about with me, camera. Are you ready? So hold on, everybody. We're on a bit of a journey. Put your leaf there. There we go. We can go here. And I read, oh, hello, see this? That's Kelly. Yep. We can stand there. Right, so let's start by the process. I think for me is that this is a joint effort. I want people just to chip in and talk about what they think we should add to this. What do we know? I know Kelly is a swimmer. I know that there's localized pain. Go through where the pain is for us, Kelly.
Left side, and then as I reach up, it's kind of down the lats and underarm.
Can you hear that okay?
Yeah.
No, okay. Yeah. Right, so I'm the person that's mic'd up, so I have to be the talker, all right? So you have to put up with me talking. Kelly presents with deltoid pain. As she comes out with her left hand and starts to push forward in her crawl position, she feels the pain down the side of your lats, down her arm, and into her fingers. And there's a restriction as you push through. There's a restriction in the deltoid. Anterior deltoid. Yeah. Okay. And also, I think there's day-to-day pain in your lower back.
Yeah.
And that's with sitting or standing or both. So a fairly constant lower back kind of ache, shoulder pain. And does it radiate up into your neck at all? Okay. You have to take your top off. So let's just start with a straightforward posture assessment. Do you agree with that, people?
Yeah, that sounds good.
You do a nod, do a walk, yeah. Okay, turns that way. I'm going to do Gilliatt's test and a little bit of assessment on that. Where would you start with assessment of the back? Where do people normally kick off?
Forward flexion and Gilliatt's.
Forward flexion and Gilliatt's. Are we happy with that? Forward flexion and Gilliatt's. Okay, so iliac crest, come together L4, come down L5, out to PSISs. PSIS is here. Sitting on that, I'm going to ask Kelly just to flex forward, just take your head forward and just flex forward. So both PSISs come up, they ride together. So forward flexion test, negative. A little bit more sticky on the right than the left, but I'll kind of work on that one a little bit. Let's just, you see that well enough with the camera? Yeah. So just bend a little bit for us again. Let's just see what the bending's like through the back. Yeah, there's not too much tighter here. There's certainly longissimus iliocostalis left side feels firmer there than on the right. Definitely more build up of tissue here than on here. Definitely tighter there on that left side. Yeah, feel that tight there. Feels solid. This side softer and more kind of flat. Okay.
Chris, if she's tighter to one side when she's doing the forward flexion, does that mean that she would be pulled over to one side as well, like when she's going forward, bending forward?
It doesn't look like that, Mark. It doesn't look like that. You know, the forward flexion looks kind of all right. She doesn't look like she pulls any one direction. It just looks tighter and more solid on this left side. Don't know. Let's do Gilliatt's test. So hand on PSI, hands on sacrum. I don't know if you can do this, Kelly. We might. Your chest, nice and slowly. Can you stand on one leg? Your hand and take it up, and then back down again, and then maybe one more time. Yeah. Yeah, that's kind of going down okay, so not too bad. And then the other one. Yeah, and back down again.
Sorry, can you just remind me, what are you actually looking for when you're doing this test?
Okay, so fingers on PSISs.
Yeah.
Yeah, so I've got my right thumb on PSIS, left hand in the middle of the sacrum, just as a guide. As she's lifting her right hip, I want the PSIS to drop. So as this goes down, I'm looking for it to, as the ilium rotates when she brings her knee onto her chest, I'm looking for this. So this is a test looking for SI joint dysfunction.
Okay, thank
Is there
you.
a tightness or restriction in SI joint? So we just lift again for me, please, Kelly. Okay, I've got a feeling that the right side seems to move slightly less. I'll come back to this one. It's fiddly, and you know, getting this right is important. So lift up this one again, please, Kelly. Yeah, okay. Again, one more time, Kelly, because they're both moving, but there's less move. What do you think, Kelly? Which one feels tighter to you? Do you have a sort of feeling of one bringing a knee up as hard on one side than the other, or not? Yeah, I think so, yeah. So both are moving, but certainly right side just feels tighter. Just less, hi Chrissy, that just feels kind of dropping down, looks tighter on the right side than the left. Generalized pain, where do you feel it? Just flat all the way around, okay. And that's with you most of the time? Okay, so generalized back pain, left shoulder issue, left spine tighter, slightly less movement in the right SI joint. Not much, but a little. Okay, let's do side flexion. Yeah, happy to do side flexion now, just to see, what do you think? Just see what's going on with sort of QL. So just ride your fingers down there, what happens there. Pretty good, yeah. And then the other side. Which one feels tightest to you? You have any real difference there, Kelly? About the same? Yeah. Not noticeably any difference. There's certainly no massive range of movement difference. Is there pain more on one? Feel it on that left hip. Okay, SI joint here. QL's range of movement, okay. spini tighter on the left side. And just arch back for us, just come back. Yeah, pulls a little bit this way. Yeah, you pull up, you're pulling that way, aren't you? So far more tighter. Can you say that? I don't know. Far tighter down the left side. Extension, although curve's okay, feels okay. There's a reasonable curve. Just seem to pull over to the left.
Does she? Sorry, I don't know if I'm not looking at this properly, but when she's doing that, does she have tightness more in the thoracic? The lumbar obviously looks like there's, as you said, quite a good curve. But when she extends back, is there restriction more in the thoracic, or is that just me?
Do you think up here? Did you?
Yeah.
This is that what you're thinking, Rebecca? Let's have a look when she bends back. So let's come back.
It seems flatter, but it might just be me seeing something that's not there.
Yeah, no, I think it is certainly flat here, but you get a real sense of a bit of rotation.
Yeah.
Of pulling it. Would you think, Kelly? Do you agree?
Yeah.
So my target, I suppose, in terms of shortness of muscle, very much left-sided compared to the right. But the SI joint is kind of unstable or tight or sticky on this right hip, right SI joint. QLs, nothing really much to talk about. Oops, sorry, kick the camera. My apologies. One shoulder higher than the other. What do you think? Look at that. You don't get camera use. I'm good at this, you know. I've wasted teaching maths. I think I should go into this camera work. This is cool. So what do we think?
Left shoulder's looking a bit higher.
Left shoulder looking a bit higher. This is a swimmer. If you want a swimmer's pair of shoulders, you got them. This is as good as it gets. How old when you started swimming? Sorry? Yeah, more build up here. Do you think? More build up on the left side.
Yeah. Kelly, what's your when you're swimming, what's your breathing pattern? Do you breathe to the same side or do you do alternate sides?
See, there's some intelligent questions coming.
More to my right because it hurts on my left.
Did you get that, Mark?
Yeah.
Yeah. Okay,
So does that? So if you had no pain, would you turn to the left or would you still always turn to the right?
I prefer my right, but I know I should do both.
Okay.
Good point, Mark. Nice one. Is somebody taking notes on this?
I am.
Right. Yes. Will you keep an idea of what's tight and what's not for me, please? Because I'm not writing this down as I go. So there's a danger of me forgetting, which I think I'll probably better do something about. Hang on. Otherwise, I'll get to a nice place where I'm thinking, what did we do last week? I can't remember. You? I don't know. I've got no idea. There we go. I'll use a Cotswold Academy pen. No, I won't. I'll use this. So let me just scribble. That's it. Hey, Mark, you like this? Hang on. Look, see? High-tech pictures.
I cannot make out what that is at all.
It's Kelly. You've got to have some humour with this, otherwise our brains are going to pop. Do you want to face that lot? Do you want to look at that lot? They're pretty ugly lot, but they'll be all right. Right, so let's have a look at the just general side view. We've got a good view there. Maybe a little bit, oops, sorry, a little bit this way so you can see the other shoulder a little bit. Is that good enough? Sort of. Protraction, what do we think?
Yeah, forward head posture, slightly kyphotic.
Rebecca's on it, isn't she? She's a guest. She's doing well, isn't she? Are you up with a bit of sarcasm and a bit of silliness, Rebecca? Well, we're harmless.
Absolutely.
Yeah, absolutely. Knee, ear really kind of protracted. So neck flexors tight. Scalene's anterior, I really want to look at. That sticks out for me when you literally, sticks out for me. Yep.
Sorry, can I just ask, does that mean that her neck flexors are obviously weak through lack of use, and then all the neck extensors from holding the head obviously forward, they're lengthened and tight?
No.
Okay.
No.
Please elaborate.
I think we've got tight pecs.
Yeah.
And tight here.
Yeah.
Tight this way.
Upper
And we've
trap.
got a lack of conditioning here and here. So in the back.
Okay, so weakness in the rhomboids and the lower
and
trap.
then the neck flexors are in that place where they're shortened and
Yeah.
lost their condition.
Okay. Thank you.
I think so. But we'll do a bit more flanger. Certainly protraction here. I don't know what you think, but certainly sort of rounded here. So there's pec work to do, pec minor and opening up through here. But there's real tense. There's lots of tissue here on this left shoulder. It feels solid and it feels kind of, you know, sore to touch. Oh, sorry. There's me digging around and it's sore to touch. Yeah, okay. So it really is sore to touch. Yeah.
Chris, would you do any tests of the rotator cuff muscle, specific sort of strength tests, and just see if there's any pain or weakness?
Yeah, good point, Mark. Good point. I think a word. Let me just pull it into here a little bit. So I might just do a couple of empty can and strength tests, supraspinatus. Is there an impingement thing going on? So we'll do this one first. So come in and just turn medial rotation. I'm going to hold. And let me hold again. Sword. Weakness. Hold. And this one. Come up. So up. Classic empty can. Hold. Any strength? No, it's okay, isn't it?
What are you doing?
So,
what are you testing for?
So I'll explain. So don't be press and hold. So you stop me. Hold. Any pain? Yeah. And this one. Hold. Solid. So what am I testing? I'm testing the tendon of the supraspinatus. Welcome to my shoulder injury, my shoulder thingy. So supraspinatus fits in the gully here. Comes through and joins onto the greater tubercle on the top of the humerus. And we're putting that under load by rotating the arm medially and flexing it and seeing if there's any impingement as it comes through under the subacranial gap. Either that the bursa is in soreness, so there's bursitis, or whether or not actually supraspinatus has a level of impingement, don't know. The fact that you've got referred pain down the deltoid and down here, there's not a lack of, when I press on it, it doesn't give way. It just feels like it locks, but there's, am I thinking supraspinatus issue? Not massively. I don't think so. I'm not there. Not really. I'll do speeds because I think speeds is good. So same kind of test.
Could it be the tendon of the long head of the biceps as well? Yeah. Possibly getting impinged.
I'm just going to test that.
Okay, sorry.
That's fine, but good, isn't she, Beck? So speeds test. So square, straight arm, and down. I'll press in here. You hold. Press in here. You hold, and then you come up like this. Hold. Yeah, and then this one, hold. Don't like that much, does it? Hold. Doesn't like that either. So both are, that's a bit positive. So I think maybe certainly bicep, long head might be impinged in there. But what I've got is a real deltoid that doesn't like life, and feeling it and looking at it. Is that supraspinatus? Question mark. Is it upper trapezius? And I've said this 100 times. If upper trap is tight, deltoid is tight. So these are I would treat upper trap and deltoid as one muscle rather than have you got problems in the upper trap, you've got problems, whole thing. There's just link the whole thing together and call it one muscle. And this is a muscle that's really suffering and feeling it. It feels in tension. It feels, my first port of call in my treatment is I've got to sort this out. That's what I'm drawn to before I start thinking about lat. Yes, maybe there's some lateral work to do. But for me, this is our kind of starting block. at the moment. I keep coming back to it in my head. Blimey, you are solid here. Feeling it, it just feels horrible. Sorry about that. Any other bits anybody wants to think about or ask about, or where do we go from here?
The medial and lateral rotation.
Yeah.
Would you do just a quick Gerber's lift off? Just check subscapularis.
Yeah, I think that's a nice one, Mark. Yeah, well, I think I would do here. Emma in the room here. Let me show you. That's Emma. She's just talked about medial lateral rotation, which is you know, key here, isn't it, as well? But yeah, I think, Mark, let's look at subscap and just see if that's kind of in an issue. So the test for that is arm behind the back. Yeah, and then you try and push your hand into my arm, and then relax, and then pushing your hand into my arm again. Okay, seems okay, reasonably good strength. This one coming through, push out into me. Yeah, weaker on this side. She can do it. There is movement, definitely, but weaker on the left and right. Yeah. So subscapularis, you know, I think it's really interesting to look at the pain patterns of the trigger point here, and and I think, funny enough, I was talking to T about this today. We were thinking about Thursday nights and thinking about how we use them. And she was saying, why don't we do a couple of sessions on trigger point pain patterns around the shoulder? Because it's so interesting to see. You know, you've got subclavius muscle here. Just turn you a little bit, sorry about the camera, just ignore. They're not watching. Subclavius that sits underneath the clavicle, pec minor, deltoid, subscapularis, that whole group, upper trap, they all give us those horrible pain patterns down the deltoid, down the arm. Is Emma's, Kelly's kind of pain pattern here to do with subclavius, scalenes, deltoid, you know, pick your muscle, really. They give, the pain patterns are so intimate and so overlaying. I think it'd be, so we had an idea that we might spend a session drawing the muscle and then drawing the pain pattern, and as a sort of a way of just having a laugh at that, it seemed like a good idea. Don't chase the pain. That's our target, isn't it, I guess. Medial lateral rotation is a goodie. Have we done enough for Kelly upright? I think we could just quickly do side, but I'm pretty sure we're going to be pretty stuffed that way and pretty nice that way. And then rotation, pretty rubbish that way. Okay, not bad. Rotation, not bad. Side flexion, pretty rubbish. So you know, again, I keep coming back to this. This feels horrible. If you were here, you'd be thinking, poor girl. I want to palpate. Let's just whiz you around. Just palpate levator, so spinal scapula along. Just levator attachment. How does that feel? Is that horrible? Yeah. So it feels like a band of tissue. So then I come 3 fingers below the earlobe side to just get the other end of that. And it's pretty horrible up there as well. So just, you know, levator scapula, a key issue here is that elevation, and because of the protraction going on, you know, that side neck, and this quarter here feels in a lot of discomfort and a lot of distress.
Is that also because it's having to take over the role of the SCM, because the SCM is weak? Yes. It's taking over the role of rotating the head. Is that right?
They're both rotators, aren't they?
Yeah, but is it tighter, because as well as elevating the shoulders, it's having to obviously hold the weight of the head and do the job of rotating. So that's why it's tighter, and because it's doing more work basically. I
think that chain of thinking is a good one. Other people think they're antagonists to each other, because the STM on this side turns the head the opposite way, where levator on this side turns the head this way. So they're going to be kind of antagonists to each other. So that school of thinking is a good one, isn't it? You know, what's the relationship between here and that head flexion, upper cross syndrome, you know, that rounding of the shoulders, head flexion, you know, that classic diagonal kind of unpacking of stuff. Okay, I think if nobody's got anything else they want to add, I'm going to get Kelly on the couch. We're going to a little play here. Welcome to the couch. This is it. Look, I'll put a sarong on it because that would be nice. You get used to my humour, Rebecca. I'm okay.
It's great. It makes it a lot enjoyable for learning.
Just go lay on your back and bring your top of your head. I'll put a towel there for you. It's nice, isn't it? And I thought I'd find a purple sarong to go on top of the black sarong. I thought that'd be nice. And it might be a bit of colour. What do you think? No good? Blokes aren't any good at this. Are we, Mark? I'll be no good at this colour stuff. We're pretty good.
Yeah, I didn't notice the colours, to be honest.
See, I think that looks like... There you go. Right, we're off down the pub now. So we'll see you all a bit later. Oh dear, oh dear. Right, okay. Let's move you a little bit further around here. Oh, hold on, everybody. We're on a bit of a journey. Oh, here we go. Let's do a bit of that. Oh, and then a bit of that. A bit of that. There you go. No pressure. Right, let's have a quick look at, so right shoulder first. Does that give you a good, yeah, you've got a good view there. If you want me to move the camera around and see other things, then just tell me and we can jiggle things around. So just pecs, I want to just see what pecs like here. I'm being pulled out a little bit there. So I guess lats, so we sort of know. But pecs are pretty tight. You can see that's not really settling back too much above the head. It's okay, but am I being pulled out? Yeah. Is pec major tight and that sort of main flexors? Yeah. I can drop into, can you see me with medial? Yeah, good. So I drop into medial rotation here. Should be able to get to about 45 degrees. Can't. Come back this way into lateral rotation. Should be able to get to 90 degrees. Kind of can. So I've got, you know, medial rotators don't want to, you know, lateral rotators don't want to let me get into medial rotation. Actually, it's all right, not too bad, is it? That's better. So nothing major going on there other than pecs. So left shoulder now. So we bring this up. Just let me know what's manageable here. Okay. So same kind of range of movement as the other side. Not massively gives me anything different. Lats don't. Interesting, you know, lats don't feel massive. You know, I'm not getting really pulled away here. Not really, little, but not majorly.
What scope do you use when you're swimming?
Crawl. That's all she does. Is that fair?
Yeah.
Swimmers, that's what they do. They don't do anything else. They just crawl. They just go crawl. Can I be sarcastic about swimmers? Is that? So lateral rotation, poor. Doesn't want to laterally rotate. So medial rotator's tight, which sort of fixed, doesn't it? Fits with where our thinking is. And here this way. Not too bad. Feels okay. You can't quite see that, can you, in the camera? But medial rotation is okay. Lateral rotation, yeah. See, it's interesting. It's not, you know, it's nothing horrendous going on there. You're not thinking, gosh, this, and the end feels kind of soft. It doesn't feel like it's kind of dropping a door on me. You know, it doesn't feel like that. So it's interesting, isn't it? Interesting. Any other things that anybody wants me to do? We're going to go a little walk.
So does that mean that it's more, obviously she was...
Go on, sorry, Rebecca.
Does that mean she was obviously very restricted in when you moved into external rotation in the left side? So does that mean all her medial rotators are super tight, so subscapularis, and that's because a lot of the swimming stroke is obviously internal rotation, so it's being really restricted.
Yeah.
And then, so does that mean that all her external rotators, so all her supraspinatus, infraspinatus, teres minor, are weak and need strengthening?
This is a good Chris Phillips answer. Maybe.
Okay. As long as I'm in the right direction.
I think, yeah, I think maybe I don't fall into the camp of weakening and strengthening.
Okay.
Because I think recently we can easily get locked into thinking, oh my God, your latero, one set of those rotators are short or lost their condition. And I think there's more and more kind of thinking that actually, if we start to lengthen muscles, the antagonists will start to work again.
Okay.
Rather than need strengthening.
Okay. So all her subscat needs lengthening.
Maybe.
Maybe. Okay.
Yeah, no, I get you thinking. And I think that's right. Although there's not massive, I wouldn't look at that and think, blimey, that's rubbish. Okay, I mean, if we're all on the couch, probably some of us continuously get tight one way. Is that really horrendous? No. Is pecs really tight? No. Is lats really tight? No. I'm not being pulled around all over the place. Range of movement is reasonable. Not great, but reasonable. What I can really pick up is the protraction here. Happy with that? Right shoulder higher. Hence, I've just dropped the camera to give you that kind of that angle. And you can see the positionings of both craniums. This one's quite noticeably higher. So the pain and discomfort is all left shoulder, but this one's really protracted. So the danger here is that we spend all our time working on that left shoulder because that is so solid, bless you. There's a danger here that's what we do rather than thinking, let's not chase the pain. Let's put the scapula back where it belongs and where it should be, and then start thinking about softening up the hard tissue. Does that make sense? Because the danger for me is that I rub where the pain is, which is your left shoulder is really sore, isn't it? And really, really giving Kelly a lot of discomfort. I could bish bash that. I was half thinking when I looked to her and I was standing up looking at it, I was thinking, I've got some cups here. I'll probably put some cups on it and really kind of break down and soften the tissue because they're solid. They're absolutely solid. But now I'm thinking, yeah, okay, that is tight and that's not great. But actually I find myself, now looking at this, I want to start my treatment here. So what do we think? Where would you start your treatment, people? I think we've done enough assessment. I don't think we need to do any more. Do you think, Mark? I don't think there's much else to say. Let's just look at anterior superior iliac spines, drop into inferior angles. They're not great. So let me just get a camera on that so you can see what I'm talking about. Oops, we're going up, guys. Hold on tight. This is good. This is good. I love this. I think I should, come out of the teaching room and start. What do you call those people that do cameras all day? What are they called? Gaffers. Is it a gaffer? Is it a gaffer? Humour me, if nothing else. Right, okay. Right, sorry, Kelly, I haven't got your head for a minute. Right, so what am I doing? I'm sitting on the anterior superior iliac spines. You see that okay? Yeah, I'm sitting on the anterior iliac spines. And I can't do this very well with a camera. I don't think I can really do it justice. But first of all, is there rotation this way? And not really. I think they feel pretty level to me. This one is higher. But when I come into dropping off the ASISs and dropping underneath, wow, then we've got a real rotation here. So I've got so there's this rotation in Kelly's pelvis. So this ASIS is lower and it's got a real kind of twist here. And that for me really is shown by SI joint not functioning too great on the right hip, and the extensors or longissimus iliocostalis down the left side are being really fixed. So this is a really interesting case study, isn't it? Where the hell do you start all this? You know, do we start always thinking about the pelvis and trying to straighten this up a bit and work on the spinae? Do you want to work on the fact that there is a real, this shoulder needs shoving back a bit and opening up with, you know, pecs and all this kind of stuff? Or do we work on the area where, bless her, she's really sore and tender? And it's 20 to 8, no pressure.
Start on the pecs in order to loosen that area and just provide a little bit of relief in the back, the traps.
Yep. So Emma's thoughts are that we should start on releasing the shoulders, and give Kelly a bit of relief. Kelly, yeah, she's fine. Oh, you haven't got Kelly's face in the camera. Sorry about that.
Well, everything you do is obviously going to have a counter effect on everything else. So by working on the pelvis and working on the spine, it's then going to have a knock-on effect on how she's standing, and so it's going to then affect the issues that are going on in the shoulder. And so so I kind of agree with, if she's come in and she's in pain, to provide some pain relief, but then long term is fixing the actual what is causing it, which actually might be coming from the pelvis and the fact that she's a swimmer, and look at that.
Yep. I'm just going to do just a pinch and slide test here. So I'm just going to push down on the pelvis here. Okay, so this is about going down to the floor. How does that journey feel? How far can I go? Is it sore and tender? Does it hurt? If it hurts on the bony bits, tell me and I'll just pop a towel over. But it's the actual journey that I'm interested in compared to this one.
Mm-hmm.
Yeah, it's pretty obvious, isn't it? So I've got a nice slide through here. I can push down to the pelvis comfortably. On the other one, I'm pretty blocked up. And I can't get very far at all. I just want to confirm, you've got legs out. I'm just going to confirm that with a Faber test, because I just want to do a quick, so I just want to just drop here and rotate and just let that pelvis drop. Can you, is that it? Yeah, sore in the hip. Yep, and then let's just do the other side. Nicer. Yeah, okay. So happy with those tests? Faber test and slide test on the pelvis here. Very much SI joint issue on this right hip. Fascinating, isn't it? That all the pain and shit is going on down that left side, but the dysfunction in terms of protraction and tightness of the SI joint is very right-sided. Really interesting. Really interesting, isn't it? And the danger here is that we've got time to do a bit of both, and we've got time to relieve some of the pain and work on that type shoulder. My danger as of doing that is, here we are on Thursday, I'd phone up Kelly on Sunday and say, "How are you getting on, Kelly?" And she said, "It's back. Feels the same." So there's a real danger here that we spend our time chasing the pain. And I'm not sure. So what any votes on this? Where do we think? What do you think, Jess? You've gone quiet on me, Jess. You've done this. You're good. You're good at this shit. You've been around for a while. Where would you start your treatment, Jess? Put you on the spot.
I would probably start with the hips, because it all originates from the hips.
Yeah, I like that. Yeah. Anybody else? Mark, where would you start your treatment?
Yeah, I'd probably agree with sorry.
Jess.
I agree with Jess. I'm kind of drawn to the pelvis and the hips and that tightness in the back. But I'd also want to, if the client's feeling that pain in the left shoulder, I'd probably want to do a bit of work on there just to see if the work that I did would help to ease some of that pain.
Yeah.
So I think.
And we've probably got time to do a bit of both, haven't we? The key bit here, of course we got some time to release off some of that shoulder, and I want her to go away feeling that we're thinking about that. But anybody else? Rebecca, have you come up with a strategy?
I think I agree. I'm just trying to understand. So would you say that her issues with the shoulder are obviously a big part is from swimming, but then would it be from the dysfunction on the right side? Would that then contribute obviously to the protraction on the right side, and then the imbalances in the upper body, would you say? So would you say it's all originating from the SIJ?
This is why I use that word, maybe.
I ask a lot of questions.
I don't. It's a good. And the question, I suppose, is: does it matter? The
No.
important thing is that we've noticed it. The important bit is that we've got an understanding of what's going on, and we decide now what we do. Does it matter where it comes from, and if it's a chicken and egg type thing? And does it really matter? Not massively. What matters is now how we attract that in a way that moves towards, you know, some.
Just putting a thought out there. Could we? Is Ishmael here?
Hello, Ishmael. You're going to let us see your ugly, your lovely face?
It's too ugly for the screen, right? So.
No. We love you. Come on. I've got an I and a K. That's all I've got.
And that's all you're gonna get.
Is that right? I've got Christina Brown. See, I've got the full words. I've got the whole thing. But I've only got an I and a K.
It's easier to pronounce the IK than my whole name.
Yeah. Okay. Hello, Chrissy. Nice to see you.
Quick.
Okay. Yeah. Go on. Sorry.
Would it be an idea to ask the patient what's her priority and where she wants to start from? Because sometimes they might want something because they know their body a lot more than where we want to. I was thinking the hips and the pelvis, but what's her priority in movement and range? Where does she want to go next to?
Tell us, Kelly. Don't say I don't mind. She wants to pay, I guess. I mean, I don't know. She's saying I don't mind, but I guess she wants to swim pain-free because her passion and her love is swimming.
Okay.
And it's like an addictive drug, and it's a bit like kind of cycling or running. It's you know, if you're not paddling around in water, you feel like you've lost a leg. Yeah.
I suppose, is that something that you would bring up in the initial consultation, what the client's expectations are from maybe this treatment and future treatments as well?
No, I don't think so, Mark. I'm not interested. Chrissy, are you going to swear at me or what? What are you going to say? You're going to tell me off? Unmute yourself, Chrissy. Come on, tell me off.
Do you know what? I'm used to using the iPad and I forgot this wasn't touch screen. Sorry.
Right.
Yeah, because they're going to be the person that's going to come back and pay you again and come back again. So if you show an interest in what they want and look after them and hopefully make whatever's bothering them better, that's a good
right.
start.
Can you take your sleeves out either side? Is that right? Does that work for you? Okay, I'm gonna because I'm here and I'm doing it. I'm gonna make a decision based on. I like the idea of the pelvis. I think this is going to be an important bit to try and get sorted, and I think I'm going to do some work on that. But I'm also worried about this, and I want to kind of get some work done here to just open that up a bit and see if I can get some retraction on pec minor and serratus. Serratus anterior. So I want to try and do that. I want to relieve off the deltoid. So I'm just drawn to the shoulders. I think it's sometimes good to move, and this is a bit, I think maybe I was being a bit provocative with you, Rebecca, I don't know, and when I say the word maybe, what I think is really important sometimes is when you're inside, and maybe this is a bit you're picking up, Chrissy, that when you're working with somebody and you're there and you're sort of palpating and you pick up there, and if you get into my kind of stuff, you know, the bit I'm really find fascinating is the energetic aspect, and actually what you're drawn to. What's your gut feeling? What takes you to a place? And the bit that I keep coming back to is here. I keep going back to the pelvis, and I'm very much that sort of horrible sort of deltoid, upper trap stuff. So for me, I'm going to start here. and you know, what are you drawn to? What are you? And I like that phrase. I know it sounds a bit vague and it's not very technical, but I think it's all right not to be sometimes. Does that answer anybody's question? No, not really.
Are you daring to be a bit holistic and spiritual?
Chrissy, sometime we'll have a chat, right? And then when we do, I'll tell you all about it, all right?
Okay.
So I'm going to use my peanut butter because I just love it. And it makes me smell nice. Well, it makes me, I don't think the client likes it very much, but I like it. I think the energetic side of stuff is probably never been quite so relevant now we're in this place of COVID. And I think we should be a little bit kinder to ourselves. If you'd like to open your mouth now, madam. Poor old Kelly. She only popped in for a cup of tea. So I'm going to put wax on me, not the client, because I just think that's easier. And I got my little pot, and I got my little pot of wax. And I'm just going to, that's a good camera. That's good, isn't it? Are you okay? You comfy? So I'm just going to really just put some stuff on me and bring Kelly up because I want to take her closer to the camera. See that okay? Does that all work? Yeah, that all works okay, isn't it? So breath in for me, please, Kelly, and just pressing on that anterior deltoid, using the on a 1 to 5. I don't want to be above a 3, 4. 1, fine. So just tell me what's manageable here, yeah? How's life with Ismail?
Busy with
Yeah,
work.
I bet you are. Bless you. I bet you're working your flipping socks off, aren't you?
Never worked so hard in my life.
Yeah.
It's all good though.
Yeah, good. Well, I know you do some really important mental health work, and bless you. You know, you're working your socks off there. I bet you are.
Mm.
So really, anterior deltoid. I want to say hello to here. Okay, 1s and 2s. Not really getting anything. No, great. So nothing much here, just a bit.
Sorry, can I just ask, when you're saying 1s and 2s, is that just the pain scale you're asking?
Yeah, sorry, Rebecca. With the general phrase I use here, 5 being go away, that's really horrible sore. 1 to 5 being our pain management, if you like. 5 would be intolerable, go away, that hurts too much. You know, and all the work I want to do is 2s and 3s, really. No more than that. So leaning on the couch, just dropping here and just dropping in. So really sitting on coracoid, and while I'm sitting on, I want to lift. Yeah, is that too much? Or just let me know what's happening. So a little bit of coracoid stuff here. Just want to set the tone here, really, and I'll come back to it. I really like kind of nibbling. I really like that model where you kind of do a little bit and then come back to it. And I think the receptors really love that. I think it fits really nicely into you know, the connection between you know, our neurological kind of pathways, the brain and the Golgi spindle receptors working together. I really like it. Easing a little bit. All right. My memory of working with Kelly in the classroom when she was doing her course here is that she's as tough as old boots. Very pleasant person, but tough as old boots.
So as you're obviously putting pressure into that area, and then you're just abducting.
Yeah.
And externally rotating more, or?
No, just abducting. Just breathe. Okay. What am I trying to do? I'm sitting on the coracoid process, and I want to get the deltoid stretching a little bit, but I've had enough of that. So now I'm going to work on the subclavius. So work through here. really, I want to work on this purely, really, because I want to kind of compare this to the other side when I get there. One thing I failed possibly to do on the mailing when Olivia and I was talking about this, that this will probably go over 8 o'clock. You know, I think we need a good half an hour to do some treatment here, to do the kind of things I want to do. So if people are happy with that, and I apologise if it wasn't, it was advertised from 6 to 7. People need to go then, of course, but I think for me, you know, to do.
You know what I notice is that you don't need to, because you're very specific, you don't need to necessarily put in a huge amount of pressure. Whereas I find when I'm treating clients, I feel like I'm killing myself because I feel like I'm putting in so much effort that my body just screams at me afterwards. And you're working very slowly, very specifically, but you know, you don't need to destroy your body in the process.
No, less is more.
Mm-hmm.
Absolutely. When it works, you know, I think certainly, you know, there's a place for working quicker. And I think we need to educate people a bit about this. And there are times, and I might have done this a bit quick. Is that okay, Ken? Yeah. So about the armpit in the face. But I think we can, I mean, I'm deliberately, I suppose, slowing it down a bit because I think it's fun to watch somebody do things differently. And what I'm reliant on, I suppose, is anatomy knowledge. Have to be. That's what I want to do here. Does that help, Rebecca? Does that give you?
Yes. Yeah. No, because I mean, I obviously am very aware of, you know, using my body in the correct posture. But I still find that I think I'm just trying to do too much at one time. So I find that I put far too much effort in. You know, when I'm doing soft tissue release and things, and I can feel sometimes my body shaking, and I know it's because I'm trying to do too much.
What drives that? Is that the pleasure that the client is going to feel good about your treatments if you pack it all in? Is it your willingness, your bit where you want to sort of get it right, and if you throw enough mud at the wall, some of it will stick?
Yeah, I think maybe it's me, obviously I understand all the anatomy, but I think maybe I'm trying to work on big areas and big groups of muscles instead of specifically just slowing it down and covering, you know, you don't have to cover everything in one session.
Yeah. No, I think it's more fun to be kind of, well, that's looking a bit better. I don't want to do it's still protracted. I don't want to do, doesn't feel right. You know, again, do you like this bit, Chrissy? It just gets to the place where you think, well, do you know what? That's it. That's all I want to do there. I don't want to do any more there. And not overthink it, and don't think just, oh God, I've shortchanged there. I should have spent longer on pec minor. So what did I do? I released pec minor a little bit, worked on the coracoid process, anterior deltoid, subscapularis, bit of MET on pec minor to try and get some retraction. I want to just get the nerves thinking this is what I want to do, and believing that this will be a couple of treatments or if not more.
So is that, sorry, when you were putting the rolled up towel, is that when you were doing the MET on the pec minor? Yeah. Okay, lovely, thank you.
We'll just come down a bit. Oh, I like this camera. This is cool. This is so cool. I'm wasted, I'll tell you on this. This is, oh. Hello, ready? How are you? They can look into your soul with that camera, you know. Right, so fingers. Just going to say hello to Kelly's neck here. It feels important to just have a little bit of a treatment up here, say hello. I want to just feel what the, I'm worried about levator's attachments, and I'm worried about that kind of gully between the spinous processes and the transverse processes. And I've got a sneaky suspicion that it's all a bit rubbish. Yeah, what do you think, Kelly? Is that 1s and 5s? Where are we? Not really, is it? It's okay, isn't it? Yeah. Not much though, is it? Do you agree? I mean, it's a little bit, but not. It's not screaming, is it? I'm not thinking, oh God, this is really horrible. A little bit. A little bit on scalenes here. Again, I'm just going to say hello. I'm not going to do too much here. I'm going to come back to it, I think. That's not very nice, is it?
Is there a reason you didn't work on the left pecs?
Sorry?
Is there a reason why you didn't work on the left side?
I'm getting there. I'm just working my way around. It means me moving the camera. No, so I want to compare that there, Kelly, that left side, and then drop across to this one. Oh, sorry. More there and there. Yeah. So scalene's certainly tighter on the left, you know, that whole area down here, sternocleidomastoid. I kind of want to come back to that. I just wanted to say hello to it. And I do that quite a lot in my treatments, and I quite like it. I quite like that kind of, the body kind of thinks to himself, okay, so he's done a bit, but he may come back, he may not. And I quite, yeah, that feels, you know, you would feel your neck and you wouldn't think, oh God, that's just horrendous, would you? It's not great, but it's not horrendous, no. Okay. Oh, let me move the camera away. It's a bit private, isn't it? Right in your face. All right, we come over here because I think we're going to have a little play with your pelvis now. Oh, well, I've got this bit I've got to do here. Oh, like this, going up, guys. Hold on tight. Oh. Hey. Hey, how you doing? You're having a lovely time, aren't you? Nice sarcasm. Just works down so well. Right, let's just turn you over. Don't mind which way you turn, whichever way you want to go. Just whatever works for you. So just a, whoops, let me just get that tail for you. There you go. Do you want a little bit on your forehead? Otherwise it... I'm going to actually take this off, I think, or certainly over the other side. Yeah, that's fine.
Please, can I ask a random question?
Random?
It is quite random to what you're doing. I'm kind of interrupting for a second, if that's okay.
No, you interrupt all you want.
Thank you. Just watching you do that and being mindful of obviously keeping windows open and stuff. I wondered if anybody else has got any suggestions. I'm thinking, I've not tried it before, about putting like a heated blanket underneath my towels or my sheet to keep people warm as it's getting colder this week.
Yeah, it's a theme for us, isn't it? How are we gonna... Oh dear, my couch is not good. Yeah.
Any suggestions, anyone? Anybody found any tips or ways around this?
I use an electric blanket, and I also have sheepskin as well. So I have electric blanket, then sheepskin, and then the sheets.
Oh, lovely.
It
that
gets
sounds good.
cold in Canada, so.
Oh, wow.
Yeah.
Oh, okay. Oh, you're definitely the person to ask. Thank you.
It's rather cool that somebody's come and joined us from Canada, don't you think?
Very
Well,
cool.
there's pros and cons to COVID. I'm very lucky to be able to be in the classroom with you.
Yeah, yeah. I haven't seen you for about 2 years plus.
That's right.
It's so nice. It's nice. You look well as well, Jess, you know? You look good.
Thank you.
Do you keep in contact with anybody on the course or anything going on, or?
Oh, I can't say I do. Unfortunately, I'm not too good at keeping in contact with people that aren't around me. Yeah, because I guess I travel a lot, so just focusing on the people that are around me is more important, I'd say. But I hope to meet up with people soon. Who knows?
Will you stay in Canada now? Is that your kind of plan?
Yeah, that's my intention at the moment. Yeah.
Yeah, yeah, cool. Okay, so I just need your help. Just want to take your shorts down. Can you help me on that one, Kelly? Can you manage that? Just take them down halfway down your legs or just off your glutes. That'd be perfect. So I can just have access to your bum. Is that all right? Brilliant. Thank you. So PSI is, can you see right? Is the camera work all right? Just, is that okay? Yeah.
Yeah, it's perfect.
So PSI is come into that groove, and then I want to just do a little bit of, is that sore? Yeah. Too much on a 1 to 5? 2. Perfect. So just a little bit of deep friction. I quite like this move. It kind of bangs the glutes and the spini together, and particularly working on iliolumbar ligament, which I think is the theme here tonight.
Sorry, so you just go to the PSIS and then you just palpate.
So PSIS is here,
Yeah.
inside,
Is that the
spine in the middle.
Okay.
And then I'm coming, here's the sacrum. So I'm coming in above the sacrum. So I'm L5, S1, and I'm working on that groove through here. I'm rocking backwards and forwards. So I'm directly working around moving, I suppose, longissimus and iliocostalis sit here, but I really want to do the deep frictions on iliolumbar ligament. That's what my kind of game plan is. I don't know. I just found it works. I just find it work. You know, try different things, and you just try different things, and you know, I found that it kind of works nicely.
Do you find, I mean, does it take time? Is it normal kind of at the beginning? I find that I always have almost a set routine in my head, which I know you shouldn't have because every client's different. But sometimes, I don't know if anyone else finds this, but you're sometimes can be so preoccupied with thinking about all the different techniques that you want to try that it can almost take it away from why you're actually doing it at the beginning when you're first, you know, newly qualified. I don't know if anyone else feels that.
Yeah, I definitely feel that. And I guess one of the problems is I tend to see people that have all got the same thing going on at the moment.
Yeah, yeah.
So yeah, it is a bit too easy to fall into that pattern. And as I've been watching it, I was thinking, I know I've got somebody I'm seeing on Monday, and I know they've got some time on Friday. So actually, I'm going to see if they're available tomorrow. Go right, do the assessment, and then I can go away and think about it, rather than just go into slight routine-y and work generally in the area. So I was thinking, yeah, if I can go away and just spend half an hour thinking about it and thinking about the different techniques in those areas, then I can perhaps get out of that mindset.
Yeah, because I just find, you know, you could spend so long thinking, right, learn all the soft tissue release or all the METs for everything. And then it's just like you throw the book at it, you try everything, and then you wear yourself out.
The other thing I tried to do with my case studies as well, to try and help that when I did my level 3, I need to start thinking about how I'm going to do my level 4 ones, is I tried to get people in with the same similar issues, so I could kind of really understand that bit of the body rather than trying to do it the whole body, if you know what I mean.
Yeah.
Rather than learn all the releases for each thing. It's like, right, okay, I'm just going to do 10 people that have got a similar issue. I know it's not always the same thing going on, but and try and do it that way.
Yeah, that makes sense, actually. That's a good idea. I'll give that a go.
I guess that's a bit harder if you're trying to get money from it as well. It's kind of easier if you've got another job on the go at the same time. So you can take your time a bit more.
It's tricky because I'm actually studying osteopathy. I'm a full-time student. So I'm just doing massage. I've just started up massage alongside it. So I'm trying to find the balance and make sure that I don't neglect either of them. But it's quite tricky.
Yeah, that's really tough.
So I'll bring your arm off, sorry. I'll bring both up. So what I want to do, Kelly, is just bring you up and then back down again. And then bring you back up and then back down again. Okay, so I'll ask you to do that as I go. All right, I'll tell you what to do. So come up and then back down. And then come back up and then back down. And then come back up. And then back down. And lift back up. And then back down. And then lift up. And then back down. And then come back up. And back down.
So just by getting her to extend up and down, is that just helping to release while you're, is that like a soft tissue release that you're doing? Almost.
It's contracting the spini group, engaging the spindle receptors, yeah, and then turning them off. So they're on and off, and it helps to relax the muscle. Really nice, simple move, as well as, of course, with the body weight of me going back on top of the multi-fed ads and in that kind of lemma groove, I'm trying to get some extension back into the, you know, that sort of facet joint movement. So trying to encourage some stuff here and getting some movement and getting some, it's a bit locked up through here. That's all there. How's that feeling there? As tender as it was?
You noticed when you were doing observations that she was more built up on the left side.
Yeah.
Does she feel different
When she's laying down? Yeah, it doesn't feel quite so fired on the left side. It doesn't feel quite as dominant. But I'm going to really now just focus on this right SI joint. And I'm keen to try and, I'm keen to try and attachment of the glute max along the SI joint, just to try and sort of make that a bit of a theme here rather than just I didn't do any lower body movement really, but Faber test was pretty positive on this right hip. How's that compared to the other side? More tender, would you say? Or? Yeah. Feels tighter. So that sort of PSIS and coccyx gives us the edge of the sacrum, that same old stuff that we keep coming back to, you know, coming along the SI joint, edge of the sacrum there, glute max attachment, sacrotuberous ligament, that whole kind of channel through. I just hit a doorstep, so doesn't want to know. Is that too much or okay? So a nice slow breath in for me, and just let your shoulders drop. Let your knees go, and the bit in between. See that? Yeah. Is that okay, camera-wise? Can you see that all right?
Yep, that looks good.
So just see what glute med trigger point is about. How's that going? Not too bad, is it? Not really, isn't it? And then here. Yeah. Interesting. So when you come off glute med and think more about glute min, so glute min, adductor, medial rotator, we didn't really look at. Whoa, yeah, it feels pretty grim there. So I'll just trigger point here for a minute. So glute min, that kind of medial rotator and adductor. Didn't look at, you know, interesting, isn't it? It's fascinating. With the more you kind of, the more you shift through the pages, the more complicated it gets, the more fascinating it becomes in terms of, you know, strength of glutes, stabilizing of the pelvis, footfall.
Can I just ask, because I've always found trigger points difficult. So when you're palpating and you're on a trigger point now, what you can obviously immediately tell, what does it, to you right now, what does it feel like when when you find a trigger point? Does it feel like a little P, or what do you find personally?
I don't come across many P's. I've got a potato here. Kelly is known for her potatoes in her glutes. No. What am I looking for? And I don't, you know, I don't think it, you know, we can all work our way through tissue, can't we? And as we work our way, we find kind of fibrous lumps, and it feels like stuck spaghetti, and an area where you just sit on it and you think, blimey, that shouldn't be there. That's not how it is. I'm not on an origin or insertion or anywhere. I'm just sitting in a tissued area where it feels very tight. So is it a P? No. I've got strands here of tissue that feel like I've got a little finger laying in here that I'm rocking over one to the other, and I'm just sitting on top of it, and it feels like I think the bit for me, Chrissy, you're like this. It's about the intention rather than what I'm doing, and I like that model of actually I'm thinking what is under my fingers within 4 or 5 millimeters. And my intention is thinking what's under my fingers in the body rather than what I'm feeling. Does that make sense?
Yeah.
So it's like the melt now. And I think if you stay somewhere for long enough, you have a sense of it melting.
Yes.
And it just gives underneath your fingers. And at that point, you think, yeah, job done. And I like that intention. I like that rather than, what am I on? Doesn't matter what you're on, does it? It's just stopping you from your movement. Am I on a black cross on a trigger point page that has told me that it's 2 centimeters down from the iliac crest? I don't give a monkeys. What matters is that I'm touching something that the client is saying, yeah, I can feel that. And I work with Kelly, with her thinking that's a manageable pain. and then I just have my intention to release it. And then I do my, you know, my there kind of, you know, my fist here just to sort of work on and just release some of that. But for me, again, it's always about nibbling. It's always about, I do a little bit and I come back to it. And I'm very aware along the SI joint sort of span here, sacrum here, coccyx here, this whole SI, PSI is here, SI joint, you know, this whole quadrant here is pretty flipping fixed. And if I jot along, and I like sort of sliding along the sacrotuberous ligament and just coming through here. And as I come across, I hit another doorstep. Actually less than I did have. Would you agree? No. Just the same kind of doorstep for Kelly, it's no different. But so I'm going to do a little bit of moving around on that because I want to get a bit of movement in there, and it feels all a bit sort of solid. So I'm going to just depress on that a little bit, and not too much, but I just want to get a little bit of SI joint kind of talking my language a little bit. And then I'm going to come back to this again. And just quickly see range of movement of Piriformis. I don't know, I kind of guessed that she's pretty good. Yeah, not great, is it? Not great. Okay. You know, I would like it to fall out a bit more, but it's pretty good. Pretty good. So I can do a little bit of thinking through Piriformis here. Okay, come around that way. A little bit of thinking through Piriformis, but I don't think there's much here to do. No, not really, is it? What do you think, Kelly? Painful. Is it painful? Yeah. Oh, good. That's all right. Just there, yeah? Yeah. So nice slow breath in and just release off if you can. Yeah. I'm kind of thinking that my treatment here is not finished at all, and I want to kind of think of laying her on her side and really kind of stripping through this whole side here a bit. Feels quite locked up through here. And I find myself thinking about hamstrings through here and what's going on here. So I'm going to drop into the ischial tuberosity and rock. How's that feel? Yeah, not tender. And I find myself wanting to sort of just have a little bit of a play here. Wake these up a little bit. No real intention other than waking them up. And then come back. And then back on that SI joint, stripping through there again. How does that feel? Not much better, is it? A little bit, but not a lot, is it? Hold on everyone, we're just having a little journey. Just want to have a little play through here. Okay, can you see all right? I'm going to move it, shout. I didn't know you better. It'd be interesting to interesting to do some cupping on Kelly and just see where the kind of stagnation is really. Posterior deltoid looks and feels pretty rubbish, yeah? You okay in the arm? Yeah. Too much or? That's fine. What's the time like? Is it 20 past? Yeah. Okay, so I could be here till 10:30 tonight, couldn't I, Kelly? Be interesting, isn't it? I'm going to retest before we finish because it'd be really interesting to see have we shifted anything. Is our SI joint any movement any better in the SI joint? Is the pain any better? Haven't targeted really a little bit round here. Not really. Haven't done much work through here at all. Little bit in the neck, little bit upper trap. I kind of thinking I might. Difficult here. This is absolutely solid, and I suppose my worry here is that I just beat the hell out of her and don't make any real sensible change. I'm gonna, if I put some cups on, are you okay with that, Kelly? The downside of cups is that you'll go home looking like you've had a kind of a lobster. Are you okay with that? Sure. Yeah. So I'm going to just, I want to pop the cups on mainly because it allows me then to do the testing and other things as well. So I can put the cups on and then test while she stands there looking like a lobster. So let's just stick something on and just see. The worst thing about cupping is your clients' partners. When they get home and they get ready for bed, they take their top off and their partners go, "What in the name of hell has happened to you? You've had a fight with an octopus or something." So I'm going to spine the scapula. I'm going to stick one on levator scapula because I don't like that much. I'm also going to stick a cup on this grisly bit of flipping SI joint down here. It was. How does that? Actually, does that feel better? So I'm going to stick one on there, but you know. And I can't get you walking around there with a cup like that, can I? Yeah. So tendon and supraspinatus and posterior kind of aspect of. Let's move you around a little bit. Oops, sorry, banged you on the couch floor. Oh, there you go. And I'm going to just drop one here into the. So breath in for me, and breathe out. Let me have the leg.
So can you just talk me through what you're doing there? Sorry.
Difficult without getting his underwear on. There you go. That looks perfect. Right. So what am I doing? So I put a cup on the side down because when I was working through that lateral border of glute max attachment there, and that's just pretty unpleasant. So I'm going to pop on there just to try and get some fascia movement. It's stagnated there and it's pretty solid. What am I doing here? I'm stretching psoas, but also at the same time I'm pushing down on the SI joint. So I'm pushing down and stretching, and I want to get some movement in the SI joint really, and I'm pushing down and lifting at the same time to get some sort of friction and move, just get some movement back in that joint area. Just push your fingers into the, yeah, perfect. So a little bit of MET on piriformis. Piriformis sits across over the sacrotuberous ligament. When it's tight, it gives chronic lower back pain. And relax, and breathe in, and relax. I just want to stretch that, and just, don't know really, just sort of working with what I'm finding a little bit. I want to keep them on if I can. I might not keep them. They might wander around a bit, but I quite like to keep them on if that's all right. See how we get on. Are you okay pulling your shorts up? Because I don't think I should do that. Is that all right? And what I want you to do is come and sit on the couch, but face me here. You okay? Are you? So take the sarong with you.
Which side do you want me?
So you face the screen. You sit on the couch and you face on this side. And I'll let you kind of. You okay? You kind of decent? Are you comfortable? Yeah, just sort of whatever you feel comfortable with. Okay.
Could you move the camera closer, please?
Where do you want it? Oh, yeah. Do you want to come around here?
Yeah, perfect. Cheers for that.
Okay.
Yeah, perfect.
No, just shout because I get a bit intrigued in what the hell I'm doing. Okay. I just want to stretch this. Oh, yeah, that's better, isn't it? Yeah. Interesting, isn't it? Fascinating. I thought that side flexion was going to be really poor because it was really poor when we did range of movement. Interesting that it's released off. I haven't done much work on it at all. Well, a little bit. Does it feel better? Yeah, it does feel better, doesn't it? That was a bit of a miracle, then, wasn't it? Bit of a blag. We did that quite well.
That's really interesting though, because I know that when I first saw her, I think, oh, the first thing I'm going to do is treat, the traps and the neck on the left side. But the fact that you've actually only done a bit of work there and worked more pelvis, spine, and it's actually had a huge effect.
Huge isn't quite the word we're looking for.
Okay, it's had
an effect. Yeah, absolutely. No, we're being cheeky. But just lay on your side. Just keep your knees bent up, but just lay on your side. Just there. Yeah, perfect. Just want to I want to get the lats working and engaging here. And it's interesting, isn't it? Because the overused side, the left side here, is the one where you're saying, gosh, my lats are just working their socks off. I'm not convinced. I think something else might be. I don't know. So I just want to do this very simple bit of MET. So are you right? Are you comfortable? Just shout. So arm on the side, hand over the. I can take these off actually. Hand over the. So you haven't really cupped up much. There's a bit of colouring, but nothing really angry or stagnated. you know, these can come up like a lobster. You know, they can come up really red, a little bit, but nothing much. Hand on the cranium, coming up to here. Now just push into my fingers here. Just, yeah, perfect. So basic bit of MET on adduction. Straightforward, and then relax forwards. Kelly, take a breath in, and as you breathe out, let your shoulder go. Let me do the work. Yeah. You get it in your fingers, yeah. Okay, so push in again. And then release. Breath in and relax. Oh, we could work all night here, couldn't we, Kelly? We could have a lovely time. You know, she's getting some referring stuff down the fingers here as I'm coming up here. So all sorts of stuff come to mind. Subclavius is one we've done there. So let's have a look at minor movements in there. How's that feel? So coming in the front here under pec major. You can't see. You can't see. This is a good move. You like this? Oh, come with me. So coming in front of, here's pec major, coming up through here, letting Kelly give me her arm, and then coming up through the ribs to feeling pec minor. And relax. I'm just rocking backwards and forwards. I'll just relax there. And then I can just move the clavicle around. Oh, yeah. Is that okay? Bit horrible. So that's where I want to be. So now I'm right at the top of pec minor on the coracoid process. Pretty feeling that, yeah. I think that's where it's coming from. I wondered about scalenes and I wondered about neck. Do you know what I mean? Because scalenes, impingement of, you know, what's it called? Thoracic outlet syndrome. But I'm not sure about that. You know, it feels here, doesn't it? That's recreating. Yeah, so here I am. So the nerve supply comes underneath the coracoid, and by pec minor, just try and give me the arm. If you, yeah, best you can. Brilliant.
So you're thinking that the tightness in the pec minor is causing that referred pain?
Yeah, well, but yeah, it's part of the party. You know. Yeah, it's starting to ease now. So I'm just trying to sort of like the whole job really is easing things as we go. All right, not too much. Is it easing off? Yeah, good. It's a really nice kind of case study, this, isn't it? It's lovely. I mean, bless you, Kelly, for being brave enough to be in front of all these people. But brilliant. You know, when you have this really live issue, where the hell do we start? How do we make this happen? Where do we, you know? And there's probably 10 different ways we could have started this. And we'll see, hopefully you can come back next week and we will carry on and I'll write some notes about where we are with this, and then we can sort of keep the journey going and just see where it takes us. Yeah, that's feeling better, isn't it? So let's just try that MET again on subscapularis. Sorry, on the deltoid and lats, and just see if that helps. So again, I'll come up. Yeah, better. So just push into my hand. 1, 2, 3. And then relax. Take a nice slow breath in for me, and as you breathe out, release. Yeah. Wow. Bit better. My God, it's Christmas. Okay, let's just sit you back up again, please, Kelly. Brilliant. So cups have done very little there. Interesting, isn't it? They've not really. I thought they were going to colour up, but they haven't really at all. So just see if that's held. Wow, nice. Can you just lay on your back for me? Just there. I just want to check the sliding movement. Oh, sorry, of the pelvis here. still rotation. We haven't really dealt with that. I'm aware of the time. If people are happy to carry on, I'm happy to carry on. So let's just push through here. So that one, yeah, that's how it was. No better, no different. This one, better, a little bit better. Not right though, is it?
No.
Doesn't feel right. It doesn't. It certainly got more range. It feels, yeah, softer. But it's. Am I getting to the back? It's not giving, is it?
No.
So let's just do a bit of. You got shorts on. Just push into my hand. Go a bit firm. And then relax. Take a breath in. Let me do the work. So basic MET on glute max now. It's tight as a rock. And then push again into me. And then relax. Take a big breath in, fill up. And then breathe out. Better. One thing we didn't really do was TFL, which is a big medial rotator. I just wonder, anyway. It's interesting, isn't it, all the time? Push into me again, please, Kelly. You know, how you kind of build that picture of where do we start our treatment and why?
So could you just talk me through why you are treating the obviously the glute max is very tight, but it's just, for me, the thing I always get is how it relates to what. So,
Yeah.
you know, it's seeing the bigger picture. That's what I always find quite overwhelming, to be honest, because obviously I can see what muscle you're testing, but you know, it's all to do with you're trying to work on that torsional strain, the torsion in the pelvis, is it?
Yeah.
Okay.
Yeah. We'll just see if that shifts anything. And I think it's a little bit of trial and error. You know, I'm thinking, do I come over and do a bit of work on Piriformis? You know, let's have a go. Better. Yeah. Okay, so I want you to come the other way now. So knee against my chest. And then relax. Gonna jerk. Ready? So push against my hand. And relax. And let me do the work. Jerk again. Not sore. Just me just shoving your knee into your neck. And one more time. So I think RI, PIR, you know, an RI works well here. You can just get, you know, antagonists and synergists working. I want to, that's better. That feels better. I've got the end there. That feels good. That should help the rotation. Yeah, now we're feeling better. So now my fingers are level rather than being rotated down. And all I've done is work on the receptors of, you know, QL, spine, you know, the whole rotational group, be that abdominal. I haven't done, you know, again, you run out of time. I would like to work down on the pubis and just see what's happening down on the pubis bone here. I guess we're tender. Yeah. So that trunk through here needs work on. And where do we start and where do we finish? We could be here till 10 o'clock. It would be lovely. We could have a cup of coffee, a bit of a break in an hour and a half and have a carry on. What have I done? I've set the stage for some kind of recovery. I've started with the pelvis and I've started to get some rotation back. And hopefully if I do the Gilliatt's test, we should see some proper dropping of that right PSIS. But that looks nice now and that looks good.
So before, sorry, was it just on the right side was dropping?
Less.
Okay, so it was more restricted on the right
Yes.
side. Okay.
Yeah. And the hypothesis is that no real joint dysfunction, but overuse of glute max. And, you know, I imagine, I don't know, we didn't get anywhere as far as this. Hamstrings. Tell me what this, okay. Yeah, hamstrings nice for Kelly. Thomas test. A little bit, we haven't gone there. We haven't gone, you know, TFL or iliopsoas. We haven't gone anywhere near that. We've just purely stuck with what we looked at the beginning. Should we have a look at that? Should we just retest that and then we call it a day? Are you okay to stand with it? Do you want to put, I can move this here. Is that help? Does that help, Rebecca? Do you get a picture, or what are your thoughts?
Yeah, I mean, I think for me, I tend to, you know, I've spent so long, you know, I know the anatomy, as in, well, or you know, all the, but it's how it all works as one. So, for example, I wouldn't even, I mean, I'm rusty, but when you're talking about the SI, I wouldn't even know off the bat, like, right, I need to test. I think I just need to brush up on, you know, some things. But it just can get quite overwhelming trying to understand the bigger picture, I find, personally, for me.
Yeah, yeah. See you next week.
Yeah, definitely.
Well, and it's only by these kind of open discussions and thinking about it, and we keep talking about it, that we come up with sort of hypotheses, don't we? Mm-hmm. What you get here now is the way that I work in my clinic. Does that
yeah.
You know what I mean? We teach aspects of this and we break it down and we do what we do. Oh, look, I like this bit. We can go down. I've got a squeaky wheel that makes you go down. It's really cool. Really nice. Right. Okay, so you just turn a little bit that way. So let's just watch you just bend. Just go over as you did before. Just come through. Still quite solid here on the left side. Just don't like that very much. Hasn't really shifted, I don't feel. Does it feel any better? No. Yeah, I agree. So, you know, in terms of spine there, have we done much work on that? Not enough. Let's just come back up again. And then extend for me. Yeah, feel straighter. You're not rotating. Do you agree?
Yeah.
Yeah. So aspects, you know, things to do. We haven't really addressed this left spinoid group. Doesn't feel like it's really kind of done much. Let's just see Gillett's. I'm hoping that Gillett's has cleared a bit, but so we do this one for. Oh no, we do left one first because this was the clean one. Yeah. So just lift up for me. Yeah, okay, that drops quite nicely and back down again. And we do this side again, just twice on one side. Yeah, okay, feels it there. And then we come across to the right side and lift up for me. Yeah, better. Lifts easier, doesn't it? There's a more stableness here. So, yeah, okay, so we've done the job of kind of freeing up through here. This doesn't really feel much different. Lats, not an issue here. For me, this seems to be more on spinoid group. I'm thinking multifidads maybe, or something, I don't know. But there's some work to do through this side here, definitely. But shoulder feels better. Yeah, just feel easier. And my worry is that Kelly will get in the pool this week and bash out 3 million miles. And when we see her next Thursday, she'll say, well, that's just as you left it, Chris. It's as knackered as it was when I was. I'm going to do, just to finish off, oh, yeah, look, 8:45. These sessions, it's difficult, isn't it, to know quite where to stop. But I'm going to do rotation. I want to just say, if you come down the other side of the couch, Kelly, and just bring your bum to here. I just want to get some rotation in your... So just sit and then bring your bum towards me. That's perfect. And then cross your chest. So arms up, like you hug yourself. Brilliant. So basic MET on rotation. I just want to see how Kelly goes this way. I'll get hold of her on her elbow. Yeah, brilliant. I've got her elbow. Tuck me in here. Sorry, you can't see. This looks good. Camera. Looks like we're just about. This is a rugby tackle that we practice. So what I want you to do is try and straighten for me, and I'm going to stop you. Just gently. Yeah, perfect. And then relax. Take a breath in for me, and breathe out, and let me do the work. And then straighten again. And then relax, take a breath in, and let me do the work. Just relax. Cool. And then we do the other way. Have a look at the elbow. And then, yeah. Got to be always careful when you do this, because A, you're right. Hold it, just relax, let me do the work. You're going right into somebody's body space, but you're also breathing in their ear. I remember the first time somebody did this to me, and it felt like they were kind of heavy breathing in my ear. It felt really weird. So straighten up for me. So I'm conscious of breathing in your ear, Kelly. And then relax, take a big breath in, and as you breathe out, let me do the work. Feel that? One more time, so straighten up. And relax, breath in, and let me do the work. Okay. Well, that would be my treatment for today. So we started at 7, here we are at 10 to 9, so that took us nearly 2 hours. But fun and games. This is one
Thank
of
you so much. That was really brilliant. Lot to take on board, and I think it's great just to be able to see it, you know, and you know, do it through Zoom is fantastic. So thank you very much.
It's good fun, isn't it? I mean, we don't often get the opportunity to see people work. I think that's the key bit of Thursday nights. We should be able to watch, and you see there's these guys in the background. They, you know, it's good to watch somebody work. And I'm not, you know, okay, I've done it a long time. That doesn't mean it means I've got something to say. But it's also, we've all got, all of us have got something to learn. So we keep talking about it, we keep listening, and we keep having a go, and we see where that takes us. Any reflections on that at all?
I mean, would your advice be really just once you just know the anatomy inside out, and that's where that's the start really, because that's when you're starting to understand the bigger picture, what, you know, and that will lead the treatment really.
I think you've got to know your anatomy well, no question. But knowing your anatomy is one thing. Knowing your antagonists and synergists is something else.
Yeah.
And those groups of muscles that run opposite to each other have got to become fluent. And once you've got that fluency, it's no good just knowing that the 4 flexors or the 5 medial rotators. Great. You've got to know the relationship between those 5 medial rotators and the 3 lateral rotators, et cetera, et cetera. And if you don't know, then MET, because MET will blag your way through it. And if you do RI as well as PIR, you can blag your way through that, which is fine. Which is what I did a little bit with that hip flexor. I want to get some rotation. Let's do RI and just see what happens. Oh, well, that corrected things. So is this a hip flexor issue or hip extender issue? QL was involved, rector spinae was involved. I don't know. Let's just do both and just see what happens. And we had some correction. You know, if we don't know, throw everything at it and see what happens. That's kind of my, that's my whole philosophy. When in doubt, blag.
Yeah.
I mean, you know, but if you don't know your antagonist and your synergist, and you're still playing around with that, and it becomes, then it just becomes like, it's hard work. Anyway, I want to thank Kelly for, she's been a staff, so thanks for that. And thanks for joining us. And it's always good fun, isn't it? And if you've got nothing to do next Thursday, let's come back together and we'll do part 2 and just see where part 2 takes us. Anyway, I'm going to say good night.
Thank you so much. It was nice to meet everyone.
Pleasure.
Thank you.
Thanks, Chris. Thanks, Kelly.
Thank you so much. Bye.
Nice to see you, Jess. Look after Canada, won't you? Take care.
Take care. Bye.